Well, I was diagnosed with an osteosarcoma in 1989 when I was 15. Unfortunately, that ended up costing me my right leg from above the knee, but fortunately, I did manage to survive with the help of some experimental chemotherapy. And this experience of being a patient with a bone tumor really inspired me to become first an orthopedic surgeon, and then an orthopedic oncologist, and then an orthopedic oncology clinician scientist. Prognosis for a patient with osteosarcoma before modern chemotherapy was somewhere between 10 and 20%. The patient would come in, get a biopsy, the diagnosis would be made, they'd get an amputation, and then several months later they would die of overwhelming pulmonary metastases, meaning the cancer had spread to their lungs, and there wasn't much we could do about that. The introduction of chemotherapy increased that from about 15% to about 60 to 70% survival. So that was a huge, huge goal and gain in the improvement of the prognosis of patients with bone tumors. But unfortunately, that was about 30 years ago, and not much has happened in terms of advancing the survivability of bone tumors. I am not satisfied with 65% survival. I think it is not acceptable that my prognosis in 1989 is the same as a patient that I diagnosed in 2014. That's not okay. We need to do better. To my mind, chemotherapy's gotten about as good as it's going to get. We have to fight smarter, not necessarily harder, and do a better job of understanding the biology of these primary bone tumors and what molecular mechanisms they are using to spread to the lungs. And that's what my job is. I want to be an expert in understanding how that happens, because once it's understood, perhaps it can be stopped. Nobody dies of a sarcoma or a primary bone tumor in their arm or their leg or their pelvis. Cancer, by definition, doesn't want to stay put. It wants to go someplace else and cause trouble. The only good thing about sarcoma is that it's predictable. We know where it wants to go, and that is almost uniformly to the lungs. So my research broadly is trying to understand how a sarcoma cell makes the difficult journey from a tumor in your femur bone through your bloodstream into your lungs to cause trouble. We call this metastatic potential, or the tumor's ability to spread. The original research I did as a lab resident was looking at the difference in gene expression and protein expression between highly metastatic bone cancer cells and less metastatic bone cancer cells. That was the data that I used to secure the OREF grant after my lab research year. That project showed us that these proteins called bone morphogenetic proteins, or BMPs, and also vascular endothelial growth factor, or VEGF, allowed us to look at how specifically these might be working. And we thought maybe with the OREF grant that bone tumors were using BMPs as a motility factor, meaning the cells are able to move around, and the VEGF as a survival factor that allows them to be strong enough to make that difficult journey from the femur all the way to the lungs. Subsequently, we were able to delve a little bit deeper into this question and demonstrate how bone tumors are using specific genes to accomplish both of those goals. And that was the data that was able to get some foundation support from the Sarcoma Foundation of America and from the National Cancer Institute. all of our department's cancer research in the Cancer Stem Cell Laboratory at the University of Pittsburgh, and the OREF grant, which I received as a resident, established some really important bridge funding. By that I mean I generated some preliminary data in the laboratory as a resident, but that isn't enough to apply for larger foundation grants or certainly for federal grants. So you need that sort of in-between funding to get you from point A to point B, which is what the OREF support did for me. It is difficult for surgeon scientists and clinician scientists, but specifically for surgeon scientists, to get funding because we're competing with people who do science full-time. And you're at a stage in your career when you're trying to learn and you're trying to build up your practice and develop your clinical skills and figure out how to teach residents and so forth. So the OREF funding is something that is really unique to our specialty and a very important and unique opportunity for us as orthopedic surgeon scientists. The OREF is our research and education foundation. This is something that is unique for orthopedists that are trying to do research. And the OREF understands that that's hard. It is hard to be an orthopedic surgeon and do meaningful research. And that's where they try to specifically help people in our subspecialty to do meaningful research. And this is really, really important because, as I mentioned earlier, we are competing with people who do science full-time and perhaps don't have the demands on their time that an orthopedic surgeon does. And the OREF gets that. And that is why it's so important to keep the OREF going, to be able to do this for people who want to do science in orthopedic surgery. We're a hard-working profession, but we're also a hard-thinking profession. And I think it's important to let the people that want to do research do it. And I give all the gratitude and thanks in the world for people who don't do research but see the value in it and support it. I'm so grateful to the OREF for helping to make this possible. In science, we spend a great deal of time asking for things and applying for grants and asking for support. You don't often get to say thank you. And I'd really like to say thank you to the OREF for making it possible for me to be a surgeon scientist in orthopedics, because it's hard to do and they understand that, and I'm so grateful.